here we have a 36-year-old woman with blurry vision, headaches, tinnitus, and papilledema also found on a fundoscopic exam. So this patient also got the same set of imaging, got an MRI orbits with and without IV contrast, got an MR venography of the head with and without IV contrast. And we have the same setup here. On the left, we have our patient. On the right is just is the same normal patient as normal reference. And you can see that our patient on the left has the same empty cella. You can see that there's this really flattened pituitary gland along the inferior aspect of the cella turcica. And again, these are sagittal T1 sequences through the midbrain, the midline of the brain. So this patient, as part of the imaging, also got axial T2 sequences through the orbits. So in this case, there was no flattening of the posterior globes. There was no optic nerve sheath dilatation. So always just keep in mind that you may not see all findings again, and there may be different variations of findings that you can see in every different case. Here, as we scroll through near the skull base of the imaging, you can see it circled that the patient's bilateral medial caves are actually quite prominent. And on the right, you can see that they're somewhat ectatic and somewhat dilated. So in addition to that, the arrows are also pointing to what are prominent arachnoid granulations along the greater sphenoid wings, the biggest one here being on the left side. So this again makes sense in line with sort of the pathophysiology that you think about with the empty cella, that the CSF space in the setting of really elevated intracranial pressures are really trying to push out and towards any direction that it can. So unsurprisingly, it sort of makes sense that a lot of it is pushing through some of the foramen in the skull base, namely here, the medial caves, as well as along and through arachnoid granulations that can become really prominent, really big, and be considered arachnoid pits. So here's another example in the same patient. If you scroll even further down, where you have an example of that prominent arachnoid granulation, that arachnoid pit, kind of extending into the right petrous apex right there. So this is a patient where you have all these prominent arachnoid granulations. And within the same MRI orbits exam, we have a T2 flare sequence here showing different views. So this is the axial view, the sagittal view, and the coronal view, different plane views. And I just want to draw your attention to that largest prominent arachnoid granulation that was along the left greater sphenoid wing. And you can see, hopefully with the signal characteristics, that there looks like there's mild herniation of brain parenchyma through that arachnoid pit. So this looks like it's a developing encephalocele. And in this case, specifically a developing encephalocele, which by definition means some of the brain parenchyma is also herniating through. And it's in these kind of cases where rarely you can run into clinical scenarios where a patient with IIH can actually present with seizures. Any situation where brain is irregularly or abnormally protruding through any kind of foramina, any kind of prominent space, you can imagine that a seizure is always within the realm of possibility. It wasn't in this patient, and it's very uncommon, but it is something that you can see as a presentation in a patient with IIH. So this patient also had MRV imaging. And you can see here that in this case, the patient has a dominant left transverse and sigmoid venous sinus with more focal moderate stenosis along the distal left transverse sinus, or some people may consider this the transverse sigmoid sinus junction. And in this case, a lumbar puncture was also done and showed an elevated opening CSF pressure of 32. Like in the first case, was started in acetazolamide, which resulted in some improvement in symptoms, but it didn't resolve it completely. Given that and the tinnitus that the patient was experiencing, the patient ended up being a venous sinus stenting candidate, where the patient ended up getting a cerebral angiogram, venogram, got pressure monitoring, and ultimately got 2 overlapping stents actually placed in that region of the left transverse and sigmoid venous sinus, where the stenosis was. This is the frontal view. You may have to squint your eyes a little bit to see that stent, but you can see the correlating image here demonstrating nice, robust flow through that stent. So there's a marked improvement in that stenosis. Let me just show you a different view here. This is the lateral view. You can see a little bit better the stent that was placed in that left transverse sigmoid venous region. And you can see a nice robust flow where there used to be moderate stenosis. Now it's just nicely open. And so very nicely after the stenting, this patient actually had a complete resolution of symptoms. The headaches, the tinnitus, the visual changes, they all resolved. So this is a wonderful example of a patient that was accurately diagnosed and very nicely treated.